Hello everyone and welcome to our module on anxiety disorders. Let's start by talking about a panic attack. A panic attack refers to the sudden onset of intense fear. In many cases it can occur with no obvious trigger and just abruptly happen. Other times it's triggered by a particularly stressful event. And panic attacks are generally brief. They last anywhere from a few minutes to an hour. Besides the feeling of intense fear, many patients with panic attacks have physical symptoms. For example, patients can have a sensation of palpitations or a racing heart. They can begin sweating, they can tremble or shake, and some patients develop chest pain or discomfort. And these types of physical symptoms are often mistaken for heart disease or something more serious than a panic attack and often lead to a medical evaluation. The diagnostic criteria for a panic attack require 4 or more of the following symptoms, and you can see it's a very long list. I won't go through all of them, but most of them are fairly obvious symptoms that someone might have in the setting of panic. Things like palpitations, a feeling of choking, or fear of dying. But I want to focus on these two at the end, depersonalization and derealization, and let's talk about those in a little more detail. Derealization refers to a sensation that the physical world around you is not real. Patients with derealization will say that items in the room around them look foggy or unreal. They can have a sensation where they feel like they're in a foreign place even though they're at home, and this is often an intensely scary experience. And so some patients describe derealization as an element of their panic attacks. Depersonalization refers to an out-of-body experience where patients feel like they are separated from their body. They can describe a sensation of being detached from themselves or looking down at themselves from above. And this also can occur as an element of panic attacks. In the video on dissociative disorders, I talk about a condition called depersonalization derealization disorder. In that disorder, patients have episodes of depersonalization and derealization following a traumatic event. But those patients don't have panic attack symptoms. When the derealization and the depersonalization occurs in the setting of panic attack symptoms, then it is simply an element of the panic attack. So anyone can have one panic attack, but patients who have multiple panic attacks may have panic disorder. Panic disorder refers to recurrent unexpected panic attacks with no obvious trigger. They don't occur following some sort of traumatic life event, and they are not occurring in response to a phobia or fear of something in the external world. In addition to these unexpected sudden panic attacks, patients have to have 1 month or more of persistent concern or worry about panic attacks and a change in behavior to avoid the attacks. So essentially, these patients are having multiple, unpredictable, sudden panic attacks, and they spend a lot of time worrying about when the next one is going to happen. Panic disorder generally occurs in younger patients. The median age at the time of diagnosis is 24 years, and it's twice as common in women versus men. There is a significant genetic component to panic disorder. Patients with a first-degree relative who has panic disorder are at higher risk than other patients. In addition, any patient who has a history of physical or sexual abuse is at higher risk for panic disorder, and then patients who experience significant life stress are also more likely to develop panic disorder. The treatment is with a combination of therapy and medications. Cognitive behavioral therapy is often used, also antidepressants and benzodiazepines. Patients with panic disorder have recurrent panic attacks with no obvious triggers. But if you have recurrent panic attacks that are always triggered by one specific thing, then you don't have panic disorder, you have a specific phobia. A specific phobia refers to a fear of a specific object or situation that leads to avoidance behavior. So for example, some patients have an intense fear of the dentist. Now if you're scared of the dentist but you still go, then you don't meet criteria for a specific phobia. But if you go to great lengths to avoid the dentist, then you may have a specific phobia. The symptoms have to persist for at least 6 months because many patients who develop an initial phobia of something will get over it within a few months. And some common specific phobias are fear of flying, fear of dental procedures, fear of blood drawing. There are many people who also have a specific phobia over public speaking. 2 subtypes of specific phobias are social anxiety disorder and agoraphobia, and let's talk about those now. So social anxiety disorder is a specific phobia of social settings, and people who have this phobia have an excessive fear of being embarrassed in social settings. They're afraid of being humiliated or judged, so they go to great lengths to avoid being in social situations. Agoraphobia refers to fear of public spaces. The word agora is the Greek word for public space. These patients also hesitate to go out in public and engage in social interactions, but it's for a different reason than patients with social anxiety disorder. Patients with agoraphobia are afraid of leaving a safe place like their home for a public setting because they're afraid of needing to flee with no help available. This is different from social anxiety disorder. They're not afraid of scrutiny or embarrassment. They're afraid of being unable to escape. For example, patients with agoraphobia will fear being on an empty bus. There are no people there, but they're afraid they'll be on the bus and unable to escape. Agoraphobia often co-occurs with panic disorder. Many patients develop agoraphobia because they're afraid of having a panic attack in a public setting and being unable to get to a safe place like their bedroom in their home. Specific phobias often respond to behavioral therapy. In particular, there are two therapies that are often used. One is called systematic desensitization. This is where the patient imagines exposure to the feared stimulus and practices relaxation. Another treatment is exposure therapy. This is where the patient confronts the feared stimulus in a safe or controlled manner with the goal of reducing the fear over time. This is a phenomenon called extinction learning in psychology. There are medications that can be used to treat specific phobias. Benzodiazepines can be used for infrequent exposure, so some people will take a benzodiazepine before they have to go out in public to calm themselves down. Beta blockers can be used because they blunt physical symptoms. Some people who are afraid of public speaking will take a beta blocker so that they don't get tremulous and sweaty when they're in front of a group of people. And for patients who have frequent exposure to the target of their phobia, these patients can sometimes be treated with SSRIs. Okay, moving on, let's talk about generalized anxiety disorder. Patients with this condition have chronic, persistent anxiety, and as the name implies, the anxiety is generalized, meaning it's about many different events and activities, not one or two specific things. To meet criteria, it has to last more than 6 months, and patients have to have anxiety symptoms on more days than not during that 6-month period. In addition to generalized anxiety, the diagnostic criteria require 3 or more of the following: restlessness, fatigue, difficulty concentrating, irritability and muscle tension, and sleep disturbance. So the idea here is that many of us worry from time to time, but to meet criteria for generalized anxiety disorder, you have to be worrying most of the time for 6 months, and in addition to worrying, you have to have these symptoms here, which can significantly interfere with your functioning. The treatment is with cognitive behavioral therapy plus SSRIs, and there have been studies showing combination therapy is most effective and more effective than either therapy alone. Patients with obsessive compulsive disorder have obsessions and compulsions, so let's talk about what those are now. Obsessions are recurrent, persistent thoughts, urges, or images. They are intrusive and unwanted, and the patient tries to ignore or suppress them but is unable to, and this causes distress. So this should be fairly easy to understand. An obsession is basically something that a person cannot stop thinking about. They're consumed by thoughts about this thing, and it interferes with their functioning and causes distress. Compulsions are repetitive behaviors or mental acts that are done to relieve obsessions. So for example, if you are obsessed about germs on your hands, your compulsion might be hand washing. If you're obsessed that the stove is going to burn down the house, your compulsion might be checking the stove. Other compulsions are things like praying or counting or repeating words, and the patient feels driven to perform these things in response to the obsessions. A very important thing to understand about obsessive compulsive disorder is that the obsessions and compulsions in this condition are ego dystonic. So let's talk about what that means now. The ego is the part of your psyche that mediates between your desires, which is your id, and the rules of society, which is your superego. So basically there are things you want, but there are rules you must follow in order to get them, and the ego mediates between the wants and the rules and comes up with a plan for how you're going to get the things you want in your life. Egosyntonic are behaviors that achieve the goals of the ego. So a patient can have obsessions and compulsions that they use to achieve their goals. For example, a patient might compulsively create lists that they follow in order to get things done. This is egosyntonic behavior because it helps achieve their goals. And you can see egosyntonic obsessions and compulsions in obsessive-compulsive personality disorder, which is different from OCD and which I talk about in the video on personality disorders. In obsessive-compulsive disorder, the obsessions and compulsions are ego dystonic. This means they conflict with the goals of the ego. In OCD, the obsessions and compulsions are barriers to goals. The patient's goal might be to get out of the house, but they can't do that because they have to keep checking the stove or washing their hands. These compulsions are not helping them achieve their goals. They're getting in the way of their goals. Those are ego dystonic obsessions and compulsions, and that's what occurs in obsessive-compulsive disorder. OCD commonly co-occurs with other psychiatric disorders. For example, many patients with schizophrenia or schizoaffective disorder will develop OCD. The same is true for bipolar disorder, eating disorders, and Tourette's. The treatment involves cognitive behavioral therapy and SSRIs. In cognitive behavioral therapy, the therapist tries to treat the patient with exposure and response therapy. This means exposing the patient to their obsessive thoughts or images and then trying to teach them to respond with non-compulsive behavior. Next, let's talk about PTSD, which is post-traumatic stress disorder. And as the name implies, this is a disorder that occurs following a very serious traumatic event, something like rape or physical assault or experiences in war. Patients with PTSD have thoughts, nightmares, and flashbacks to the traumatic event, and they engage in behavior to try and avoid reminders of the trauma. Because of these intrusive thoughts about the traumatic event, they become hypervigilant, so they can be anxious and alert and scanning. And the constant thoughts about the trauma also lead to sleep problems. They can be restless and unable to fall or stay asleep. And all of these things work together to lead to social dysfunction. The diagnosis requires, obviously, exposure to a traumatic event, and then symptoms of persistently re-experiencing the trauma either through thoughts, nightmares, or flashbacks. The patient has to avoid trauma-related stimuli. So for example, if it was a soldier like this man here, he would avoid things that remind him of the war. The patient has to have negative thoughts or feelings surrounding the trauma. And the patient also has to experience trauma-related arousal and reactivity, meaning thinking about the trauma gets them worked up. And then finally, the symptoms have to last for more than 1 month. Many patients experience these symptoms briefly after a trauma. When they persist for more than a month, that's what defines PTSD. The treatment of PTSD involves cognitive behavioral therapy plus antidepressants like SSRIs or SNRIs. One special treatment for PTSD that you should know about is the alpha-1 blocker prazosin. This drug generally knocks down sympathetic nervous system effects, and it's been shown to reduce nightmares and improve sleep among patients with PTSD. One of its important side effects you have to be aware of, however, is that it can cause orthostatic hypotension, and patients can develop dizziness when they stand up for this reason. And then lastly, you should be aware that benzodiazepines and opioids are generally avoided in PTSD. Many patients self-medicate with alcohol and develop alcohol use disorders with PTSD, and there's a high addiction potential among these patients, so benzodiazepines and opioids are avoided. Acute stress disorder also develops following a traumatic event, but it's a short-lived disorder that lasts less than a month. To meet criteria for this disorder, patients have to be exposed to threatened death, injury, or sexual assault, and this has to lead to recurrent intrusive memories and recurrent distressing dreams. Patients can also have dissociative symptoms. This refers to an altered sense of reality. They can describe feeling like they're in a daze or time is slow following the traumatic event. Sometimes they can't remember aspects of the trauma. This is called dissociative amnesia. But unlike PTSD, which is a chronic disorder, acute stress disorder resolves in less than 1 month. And the treatment is with cognitive behavioral therapy and no drugs, because this is usually a self-limited disorder. Adjustment disorder refers to behavioral or emotional symptoms that develop within 3 months of a stressful life event. So in contrast to PTSD, which develops after exceptional traumas, things like assault or war, adjustment disorder can develop after a stressful event of the type that we all experience, things like moving to a town or starting a new job. These types of events can cause distress in anyone, but in a person with adjustment disorder, they cause distress that's in excess of what's expected or usual, and it leads to an impairment in daily functioning. Importantly, adjustment disorder cannot meet criteria for another disorder, like depression or an anxiety disorder, and it usually resolves within 6 months, and the treatment is psychotherapy of various forms. So in a board question, the way to recognize adjustment disorder is to first of all, notice that it occurs within 3 months of some stressful life event, like moving to a new town or starting a new job. And then importantly, when you see that the patient has impairment of daily functioning, this may make you think that it could be an anxiety disorder or depression, but it won't meet criteria for any of those other disorders. And then also importantly, when they ask you for the treatment, remember that it's psychotherapy and usually not any type of drug treatment. We'll finish by talking about body dysmorphic disorder. This disorder occurs in physically normal patients who become preoccupied with their physical appearance. They often focus on non-existent or minor defects in their body, and they believe they look abnormal, ugly, or deformed. And because of their preoccupation with their body, they develop repetitive behaviors like checking their look in the mirror or combing their hair. And so this shares some resemblance to obsessive compulsive disorder, where the patient is just obsessed with their body image. And in fact, the treatment is the same as obsessive compulsive disorder. It's with cognitive behavioral therapy plus SSRIs. And that concludes our module on anxiety disorders.